start our presentation today. I want to check if everybody is seeing us and hearing the voice is very clear.
Hello, can you hear me?
Yeah,
Yes,
we hear
we
you.
can do it.
Discuss innovation in constipation for pediatric patients with Margaret. Margaret, we will start our meeting. Please, everybody should mute the voice, and everybody make sure the bottom of a voice is mute.
So today we're going to talk about management of constipation in the pediatric patient. We're going to look at the products, techniques that are used for kids. So thank you everyone for joining today. So just a quick overview. We're going to talk about normal bowel function, common causes of constipation in the pediatric patient, products and techniques for managing constipation. So constipation is a frequent complaint. It actually accounts for about 8% of the visits to the pediatricians, and then about 25% of the visits to that pediatric gastroenterologist. Constipation is defined as a delay or difficulty in defecation present for 2 or more weeks, and actually sufficient to cause the patient and come in on a constant basis because of the constipation. You know, this includes many definitions, but it includes signs, symptoms, and timeframes that are very similar to the outline definition. Constipation is a very common issue, both in the primary care setting and also in secondary care. Prevalence of functional constipation in children ranges from about 4 to 36%. Children may fear going to the bathroom. I mean, it's a common thing. These little guys are home, they're with their mom and dad, and all of a sudden they're put out into the world, visiting friends, going to daycare, basically even in public places of shopping. And this has a social impact on them as far as going to the toilet in public places. There's a large cost of constipation in our economy. Basically, children with constipation used more health services than children without constipation, actually resulting in significantly higher cost. You're looking at a difference of about $3,430 a year versus $1,099 a year. So what does this amount to annually? $3.9 billion associated with children who have constipation. Now, I'm sure you're all familiar with normal bowel function, but basically just to go into it a little bit. So humans of all ages, as we know, are constantly making stool. So through the large intestine, but once it gathers to about 15 cc, it enters the rectum or the anal canal, really activating those stretch receptors. The intramural plexus are then activated and send that response to the brain through that spinal cord, and bowel function is parasympathetic. So that parasympathetic response, your rest, digest, feed, breathe, it's that sympathetic response that occurs when the body, parasympathetic response that occurs when the body is at rest, especially after eating. The internal and the external anal sphincter. Really, these two have to work in concert. You know, more commonly, they're known as the EAS and the IAS. So these two sphincters are within the last 6 centimeters of our intestines. The IAS, which is not under voluntary control, and the EAS, part of which is a muscle, which is under voluntary control, usually by that age of 2. You know, correct functioning of both of these is essential. You know, you must absolutely maintain that tonality. And unfortunately, when these kids have constipation, it stretches, and we need to maintain that tonality. So let's get down to really basics here. So you have that rectum distension. And then what happens? So your external anal sphincter and your puborectalis muscle, they contract. And then also you have that internal anal sphincter, and basically that relaxes. So what happens? You get this defecation urge. If it's appropriate for that child to go to the bathroom, what happens is the EAS and the PR relax, and then there's stool passage. However, if this little one is at daycare or out and about shopping with mommy, and they don't want to use a public restroom, they feel it's not appropriate to go, so that EAS and the PR, you know, it remains contracted. It's not going to relax. So then what happens? The IAS recovers tone, and the defecation urge then passes. The Bristol stool chart was actually designed in the 90s, and basically in Bristol, England. And what it does, it classifies 7 types of stool. And it's based on the type of stool and actually the transit time within the colon. So when you're looking at this type 1 stool, those hard, rocky pellets, I mean, basically what you're looking at as far as transit time is about 100 hours. And this is something that all parents really need to take a look at and ask their children, have they gone potty? You know, and look at their stool to make sure they're not having those hard, dry, rocky pellets. And then when you're looking at that type 7, I mean, it's about a 10-hour transit time. So again, you know, for those parents with those constipated kids, it's really, really important to know the type of stool that they have. So functional constipation, the majority of children and toddlers, about 95% actually, have reported cases of functional constipation. Functional constipation actually has no medical cause. Functional constipation in children is defined as constipation not associated with a congenital abnormality, acquired disease, or medication. The passage of infrequent, extremely large, hard caliber stools is highly suggestive of functional constipation. So fecal soiling, this is really, especially after a child has been toilet trained for some time, the fecal soiling really suggests rectal impaction from that constipation, that functional constipation. Approximately 3 of every 4 children with constipation have pain, and the child that has pain isn't going to want to have a bowel movement. So this has to be dealt with early on. Actually, in 2015 alone, functional constipation had a worldwide prevalence of 15 to excuse me, 45%, with approximately 40 to 75% of chronic constipation in children resulting from fecal impaction. You know, it's helpful for the parents to keep a diary, and I'm sure as providers, this is something that's recommended. Keep that diary, a particularly a food diary of the type of food the children is eating, as well as how the child feels after eating. Pay particular attention to the amount of fiber in their diet. Daily fiber requirements for children may vary, as we know, depending upon their weight, their gender, and other variabilities. So basically, the parents are looking to you for this information. The history may show that a child with constipation has a low fiber diet. So it's important that we get lots of fruits and vegetables, eating that balanced diet that's high in fiber, fruits and vegetables, and grains really helps maintain that really healthy gut health. Foods high in fat, salt, sugar, should be avoided because they can cause overgrowth of that bad bacteria. So, and also, hydration is extremely important for these little ones. So, organic constipation. So the prevalence of certain, of certain red flags have been revealed upon the physician's exam. I mean, basically, this should raise suspicions of organic disorders and necessitate an investigation. You have diseases like Hirschsprung's disease, spina bifida, hypothyroidism, cystic fibrosis, congenital anal rectal malformation. These are all signs, obviously, of organic constipation. Hirschsprung's disease, for example, is a condition that affects the anal rectal malformation. So when you're looking at Hirschsprung's disease, it's a condition that affects that large intestine and causes problems with passing stool. Hirschsprung's disease is present when a child is born or congenital and results from missing nerve cells in the muscle or part of all of the baby's colon. So a newborn who has Hirschsprung's disease is usually unable to have that bowel movement within those first few days. But if a condition is mild, the condition may not be detected until later in childhood. Hirschsprung's disease is treated with surgery to bypass or remove that diseased part of the colon. And then when you look at conditions like spina bifida, this occurs when the backbone and the spinal cord, the spinal canal do not close and actually roll into that new tubular structure, that normal tubular structure. So, which actually completes that spinal cord column before birth. So many times the higher level of injury, the more severe the disease is. And usually these patients have issues with this lumbar sacral area, with the disease affecting that area. For the most part, these patients are going to have a flaccid bowel. So their rectum pretty much is going to remain open most of the time, and they may have that drippage that occurs. And that's why, particularly for these patients, it's very important to have a good bowel care program on board. Whether it's for spina bifida, cystic fibrosis, a bowel care program is essential. But there are many things that stand in the way of a bowel care program for these kids. And it could be, really non-compliance is a big factor here. Non-compliance and having that consistent bowel program. There could be social issues, time management, just really lack of motivation for these patients. And it's only a few things really that go on with these patients with organic constipation. So chronic constipation. More than 90% of the pediatric constipation cases have no organic cause. Constipation becomes chronic when it lasts for more than 8 weeks. Chronic constipation can cause adverse health effects, including colonic distension, anal fissures, involuntary soiling, and abdominal discomfort. It may also hinder growth of the child's development. So fecal incontinence is caused by chronic constipation and is involuntary. So this liquid stool that leaks around the hard stool that's retained in the colon actually has significant ramifications on the child. I mean, it's embarrassing. You know, research shows that children with chronic constipation actually have a worse quality of life than those that have more severe medical issues like irritable bowel syndrome, gastroesophageal reflux. So in actually a European study, it was noted in the Journal of Pediatrics that 25% of children that actually have constipation as a child go on to have constipation as an adult. So in patients with chronic constipation, what happens is you have that overstretched rectal wall and it desensitizes to the sensation of being full. So it's really important that these patients get on a good bowel care program and help prevent that relapse and allow a proper size and function to return. So, steps in the approach. So having a good program on board, many providers employ various laxative therapies along with diet, behavior modifications, and lifestyle recommendations. Okay, proper positioning for these kids. So how are they doing it? Remember to always encourage proper positioning. Our little ones should have those knees high, higher than hips, lean forward with elbows on knees, bulge that abdomen forward and straighten that back. Now we're going to review some ingredients found in stool softeners and laxatives. There's a lot out there. I'm going to focus on basically the stool softeners, those lubricant laxatives, the mineral oil, the stimulant laxatives, which would be your bisacodyl and your senicides, and those osmotic laxatives. So stool softeners. In most instances, this is the first thing that's being used, at least in the United States. So they work to allow water to get into the stool. It works by getting that mucosal lining to basically expel moisture to soften that stool. The oral formulations take about 12 to 72 hours to work. Now, there is a docusate sodium mini enema, and this provides evacuation within 2 to 15 minutes. So the rectal usage of stool softeners work faster and more efficiently because it's absorbed into the bowel and initiates that peristalsis actually immediately. Now with mineral oil, basically what you're going to find is that it coats the stool and the inside of the bowel with moisture. It helps keep that stool from drying out. It's available in oral, liquid form, and also enemas. There's a couple things, obviously, that you need to be aware of, which I'm sure you are. It's important that patients take it before bedtime, so they don't have to worry about waking up in the middle of the night. Basically, avoid taking it with meals because this can interfere with the absorption of certain nutrients. And basically, don't take mineral oil within 2 hours of taking medication because it can interfere with the medication's effectiveness. Your stimulant laxatives. Actually, the colonic stimulants promote that peristalsis by stimulating or irritating the bowel wall to promote motility. So you have your senosides and your bisacodyl. The bisacodyl actually is an irritant. There's both an oral and a rectal formulation. Little bit about the rectal formulation, the suppository. So with this, it basically what it is, it's an irritant. It burns the rectal area, and actually it almost looks like a colitis state has occurred. So when you're looking at bisacodyl, you can see that actually neutrophils persist for up to 3 hours. And actually, if you stop using bisacodyl, you can have mucosal discharge for up to 3 days. Now let's look at your osmotic laxatives. You have your polyethylene glycol or your PEG 3350. And basically, with these osmotic laxatives, again, you're pooling water to hydrate and soften the stool. They do take longer to work. I mean, under osmotic laxatives, you have the lactulose, takes up to 48 hours. And the PEG formulation, the PEG 3350, actually can take up to 1 to 3 days. You have your glycerin suppositories. Again, they work a little bit faster. The rectal formulation, it takes 15 minutes to 1 hour to work. And there can be a burning or a cramping sensation. And then you have your sodium microenemas, and basically sodium citrate microenemas. And basically, again, they work to soften the stool and gently empty the contents. Again, the rectal formulations do work faster, 5 to 20 minutes. And then lastly, you have your sodium phosphate enemas. These are your larger volume enemas, and basically they work quickly. But in the United States, what happened is the FDA issued a warning in 2014 that basically these large volume enemas can cause harm to the kidney and heart. And actually, there have been deaths associated with some of these large volume enemas. I wanted to get into a couple trials that were done with the docusate sodium mini enema in the treatment of patients with constipation. There's a lot of information on here, so I'm just going to highlight it. This study took place over a year, and it was a single center open label that was conducted to determine basically the safety and efficacy of the docusate sodium mini enema in patients with constipation, and they use this on an every other day basis. It was shown to produce a bowel movement in an average of 10 minutes. You can see there on the far right from application. And none of the patients in this study incurred any fecal incontinence. There were no events of fecal incontinence. And not only was the docusate sodium mini enema shown to reduce the occurrence of bowel incontinence, but there was no burning or seepage of the mucosal lining of the lower bowel. So The other thing that was interesting is that there was a satisfaction rating. So it was used on a scale of 0 to 5, 5 being the most satisfied. And all the participants in this study, except for one, basically gave a 5 to the docusate sodium mini enema. The one patient gave it a 4.93. So the satisfaction rating in this particular trial was very good.
More chat.
Hello? So this is an interesting trial. This study was done in spinal cord injured patients in adults, and this is the House-Stein study. And basically what this looked at was the bicocodal formulation that two of them, one with the vegetable solution and the other with the coating rather, the vegetable solution coating, and then the other one with the polyethylene glycol coating. The polyethylene glycol does work a little bit faster than the vegetable solution, but you can see here that because the vegetable solution needs that heat to dissolve, it does take longer. And you can see that the docusate sodium mini enema basically had less than half the incontinence episodes compared to the bicocodal polyethylene glycol formulation, and provides an evacuation in 35 minutes versus 75 minutes with the bicocodal. And again, this was done in spinal cord injured patients, and that is one area, obviously, that that these patients need some sort of therapeutic method to achieve defecation. Actually, 95% of these patients do need some sort of rectal formulation. So bowel management, and basically with the docusate sodium mini enema, the nice thing is that it's been around for a very long time. It's a non-irritating formula with easy rectal usage. It's a 5 ml enema. And basically it helps with those patients with both functional and organic constipation. The children's version has 100 milligrams of docusate sodium with excipients of PEG and glycerin. And then that is indicated for kids from 2 to 12. Your docusate sodium mini enema for 12 and up has 283 milligrams of docusate sodium with excipients of PEG and glycerin. It works within 2 to 15 minutes, basically without any mucosal discharge and virtually no incontinence. So some takeaway points. Education, education, education is so important for these parents, helping them understand, obviously, that diet is so important for these kids. You know, starting them off slowly with some of their high fiber things that they love to eat, and, you know, being a little tricky by grinding things up and mixing it in with their food, and obviously keeping these children well hydrated, lots of fluids, but not sugary drinks, and really managing that functional constipation and management of organic constipation. And just to highlight too that, you know, 25% of these children that have constipation as kids will end up being constipated as adults. So it's very important that they tackle it early and get them on a good track to be constipation free. So that is pretty much it for my presentation. I didn't know if there were any questions.
Thank you, Margaret, for a great presentation. Now we can start the question. We have one question from one of the delegates, doctor. He said, what age is safe to use such products for pediatrics, and for how long we can use it?
So basically with the little guys, our docusate sodium mini enema is approved here in the United States for children between the ages of 2 and 12. And basically you can use it as long as they are constipated. I mean, in spinal cord injured patients, the product has been out here in the States for a little over 17 years. And basically, we have spinal cord injured patients that use it on an everyday or every other day basis. So it is safe and effective. There have been no violations against us with the Drug Administration here in the United States. So it is a safe product.
So very safe product. Okay. Okay, we have another question from delegates. If doctors, dear doctors, if you have any question, just unmute the button, the voice button, and you can ask. Okay. Okay. We have feedback about the product. Any other questions from the doctor?
Hello, good afternoon.
Good afternoon.
Hello
Doctor.
there.
I have one question, please.
Yes.
Yes, sure.
Thank you first for that nice presentation. Please, I want to ask about the difference between glycerin suppository and the mini enema in the action. What is the difference?
I'm sorry, the difference between the mini enema and what was the other one?
Glycerin suppository.
I'm not familiar with that. What is the active ingredient?
Glycerin.
Can you help me out with this, Ahmed?
Glycerin.
Oh, glycerin.
Yes.
Glycerin, thank you. Yes, basically, we can go back on the slides here. So your glycerin is sodium free and basically works to soften that stool. So it works like similar, it's a hyperosmotic, so it's drawing those fluids in. However, there can be a burning sensation and a cramping associated with that rectal formulation. It works between 15 minutes and 1 hour, so it does take a little bit more time than the mini enema does.
So please, for how long the enema can be used?
So as I mentioned earlier, it can be used as long as the child is constipated. We have been using this mini enema in spinal cord injured patients for over 17 years, and these patients use it on an everyday or every other day basis. Obviously, you just want to get these patients back to where they want to be normally. So as long as they're constipated, getting them on a good bowel care program. But obviously, if they have organic constipation like spina bifida or cystic fibrosis, this is more of a long-term thing that they're going to have to deal with.
Okay, please, the last question. It doesn't affect the bowel movement?
What, the mini enema?
Yes.
Yeah, so basically what it's doing, it's softening up that stool in there. And basically with that mini enema, because it is docusate sodium, it's really producing that natural bowel movement for these children and adults with the adult formulation of the docusate sodium mini enema.
Okay. Margaret, we have another question from one of the doctors. He is asking if docusate sodium is not working, what is the second line we can use, and any role for combining the product with other products?
Yeah, so Usually, one thing to keep in mind, it's really important on administration with the docusate sodium mini enema that you remove any stool that is low down in the rectum. I mean, you need to manually remove that stool because you don't want to insert the mini enema into the stool because it requires the moisture from that mucosal area to soften that stool. If you put the mini enema into the bowel matter, into the fecal matter, basically it's not going to work. So as far as an approach is concerned, basically you can use oral formulations to help move that content down because it may be required in some patients because they have that incredibly slow transit time, and then use the mini enema. But then once they get into a normal routine, obviously you can back off on the oral formulation until, you know, you want to keep them with as few medications on board as possible. And then if that doesn't work, there's so many other laxatives and rectal formulations out there. I guess it's what's best for the child at that point.
Oh. Okay. We have another question here from one doctor. He is asking about the usage of enema for a long time. Can it cause anal fissure? And can we use it for a long time? It will cause.
No, actually, in the adult formulation of the docusate sodium mini enema, we actually have the addition of the 20 milligrams of benzocaine, which is actually for patients that have those anal fissures because it helps with that pain. And actually, there have been no reports with the mini enema of causing anal fissures.
Okay. Okay. Okay, we have another question from the doctor. He's saying he noticed a few adults don't respond to the product. What is your feedback about this? If even he doubles the dose, is doubling the dose, and yeah, okay.
Yeah, so basically in adults, not with children, because actually in the United States, we're only indicated for children to be used once. But for those that are 12 and older, you can use the docusate sodium mini enema up to 3 times consecutively, a half hour apart. So you can do that for those that are 12 and older.
Okay. Is docusate sodium safe from which age? The same question we answered. But
yeah, from the little guys between 2 and 12, that's the 100 milligrams of docusate sodium. And then for the adults, you know, basically 12 and up, you can use the 283 milligrams of docusate sodium mini enema.
Okay, do you have any statistics about how many patients don't respond to the enema?
Yes, basically over 87% of the patients that use the docusate sodium mini enema have a great response. So almost 90% of the patients that use it will have a good response to the mini enema. It's not 100%, but we're close.
Okay, sure. Sure. Another question, please. When we can use procalopride?
I'm sorry?
They ask when we can use procalopride. This is another product.
I'm not familiar with that product. We may not have it here in the States.
Maybe we don't have it. Okay. We have another question. Is there any other adverse event or adverse effect for long usage of enema?
Yeah, I mean, you just have to worry about an allergic reaction. I mean, that's the basic warning with our mini enema. And we don't have any indication for pregnant or lactating women either. So, you know, obviously that's up to the physician to determine if it's appropriate.
Okay, from your experience, what is the next step if the patient refuses to take the enema?
Well, again, I'm not a doctor, so it'll be up to the doctor what the next step is. But you know, there are so many different things out there, and I think it's, you know, basically whatever the child is amenable to and the parent is amenable to. Because I know so many times, you know, we as parents have gone through this with our kids, that they get this gagging and choking reflex if they take any type of pills. That's why the mini enema is a great, basically, substitute for some of the oral formulations. And also it works pretty quickly. So that's also good, because then the kid can go off and have fun for their day.
I have a question, please.
Yes, please.
Go ahead, doctor.
How effective is docusate sodium when we compare it with the phosphate enema? And if somebody is using the phosphate enema and he want to substitute the phosphate enema with docusate sodium, is it a good idea when we shift from phosphate enema to docusate sodium? It will be the same as effective as the phosphate enema?
So you're talking about the sodium phosphate enemas? The large
Yes.
volume enemas? Yeah,
Yes.
so I mean, basically you're looking at these large volume enemas. They have a very purgative effect on that, you know, rectum. I mean, it's just evacuating everything. And plus the fact, you know, it can create an electrolyte imbalance with these patients. So, I mean, it is absolutely not recommended to be used. And you can see right here on the slide, one enema in 24 hours, and it shouldn't be used on any type of consistent basis because of the fact, you know, it can cause that electrolyte imbalance. And many of the facilities in the United States actually have stopped using the large volume enemas because of all the issues, and basically substituting, you know, either the docusate sodium mini enema or the formula for bisacodyl has been used in many facilities as well.
Actually, here in UAE, it's the regulation for the phosphate enema. It's almost very similar to the States, because actually here the phosphate enema, we are not supposed to use it
Okay.
for the pediatric.
Yes.
3 years. It's
Wow.
not, according to the Ministry of Health regulation, we are not supposed to use the phosphate enema, not only because the electrolyte disturbance only, but also because of the phosphate toxicity. It's the phosphate toxicity we have to consider.
Phosphate, yes, exactly.
Yes, yes. That's why I guess the efficacy of the docusate sodium, it's not that much far from the phosphate enema. In the same time, the side effect of the docusate sodium, we can consider it very safe comparing to
Very
the phosphate
safe.
enema. Yes.
Yes, exactly. Thank you. Yes.
So I think it's an excellent solution for the pediatrician to use it if he wants a strong medication and in the same time effective one.
Yep. Yep. Very good.
Oh, okay. Thank you.
Thank you very much.
Thank you. Okay, we have another question, Margaret, please.
Yes.
For adult people above 50 with chronic constipation, can we use it? Is it safe to use it, and for how long? Especially if these patients are diabetic.
Okay, well, you know, it's interesting because, let me just get to this slide here. Here we go. So in the States, we're not indicated for chronic constipation, but actually in this particular study, it was used with patients with chronic constipation. And basically in this particular trial, they used it on an every other day basis for a year. It went from April in one year to April in the next year. So it was used in these age groups, 25 to 54, and the majority of them were 65 plus.
Okay. Another question, what is the treatment for child less than 2 years?
We don't have anything with the docusate sodium mini enema at this time. So the indication is 2 and up.
Okay. I think this is the last question. Are there any adverse effects for long-term use of big 3350?
The long-term use of the docusate sodium mini enema?
No, the big.
polyethylene glycol.
Okay, doctor, go ahead.
I'm sorry.
Hello?
Hello, I'm here.
Yeah. He's asking about another product.
I can't talk about the long-term use of other products. You know, I can't talk about that. I mean, I can give you the basic information.
Polyethylene glycerine. Hello?
Yes, I'm sorry.
This is, you know, the page. Okay, he is asking about the long usage of polyethylene glycol. This is the base of
polyethylene glycol.
Yeah.
Yeah, you know, it's interesting. Let me just go back here. The PEG solution, the 3350, actually, in the United States, back several years ago, many of the parents actually reported neuropsychotic issues with the PEG 3350. That's the most popular one that's used here in the United States. And actually the Federal Drug Administration, because there were so many complaints of like depression, anxiety, all kind of things with these kids, because technically this product should not be used here in the States for people less than 17. And some of the doctors have been using it for, you know, kids, the little guys. And this is the result that has been happening. And you can just look it up. The you know, the PEG 3350. So and the PEG in our solution, we do have an excipient of PEG, but it's not the 3350, it's the PEG 300. So it's different. And it's just an excipient, it's not the active ingredient.
Okay. Another question, please, for safety in pregnancy. How we measure the safety of the product in pregnancy?
Again, that's up to the it's up to the doctor. We have no studies that have been done in pregnant women, so it's totally up to the doctor to make that determination.
Okay. Any other questions, doctor? Okay.
Yeah, I have one question.
Okay,
yes.
Doctor, go ahead.
So do you think for pediatric patients, do you prefer an enema, or do you recommend DocuSit first, as long as like they're in the right age range?
So I'm not a doctor, and again, it's up to you. But as I said, particularly with anybody with organic constipation, many of these patients will need some oral formulation to help manage that hard, dry stool through the colon, and then using our mini enema to help rectally to, help with that evacuation. So I know that the oral docusate sodium, at least in the States, is used first line for many patients. But again, it's basically up to the doctor to make that determination.
Okay. All right. Thank you.
Thank you.
Okay. We have another question, Margaret, please.
Yes.
Which enema is safe for children under 1 year?
I'm not sure. I don't know if there's anything, at least in the States. I don't know of an enema that is used for less than 1 year old. So I'm not sure about that question.
Okay.
I'm not sure if you have anything in the United Arab Emirates that you have less than 1 year, but we don't have it here in the States.
Okay, sure. We don't have. Doctors, any other questions? Okay.
What about Senna? Can you use Senna? From what age group do you recommend using Senna?
Again, Senna is a stimulant, just like bisacodyl, so it's going to irritate that lining. And it does take a little bit longer to work too. It takes from anywhere between 6 to 12 hours to work. And again, you don't have that predictability with the Senna. So, it's totally up to the doctor to make that determination. But again, it is a stimulant. It is an irritant.
So if my understanding is correct, the Docusate can be used more than 2 years as an enema, if I'm right. Please correct me if I understood that. Thank you.
The Docusate sodium mini enema can be used for ages 2 to 12. That's the Docusate sodium mini enema. That's 100 milligrams of Docusate sodium. And then for 12 and older, there's a 283 milligrams of Docusate sodium in a 5 ml mini enema.
One of the biggest challenge we have is, when these children are constipated, putting an enema can be a very painful experience for them. They wouldn't allow us to put the enema, and it can be more distressing. So what are, your thoughts about this, and how can we overcome this kind of a situation, please? Thank you.
Well, the nice thing about the Docusate sodium mini enema, it is small. It's a 5 ml.
To ask is, one of the biggest challenge we have is,
the enema
so
insertion.
distressed.
Yes. So basically, there's 2 ways that you can administer the enema. The best way, obviously, is to lay on your left side, because that's the natural flow of how the bowel goes, and basically put the legs sort of like lay in that fetal position. And the mini enema, what's really nice about it, it's very, very small. So it's only a 5 ml. Like when you look at these large volume enemas, I mean, you're looking at 133 ml. So, for those large volume, and I'm sure the pediatric, I think there's a pediatric enema here in the United States that's like a 65 or 68 ml, but it's still, pretty large. Is that, the neck of it is very small. So it just goes into the rectum. So I don't know if you've tried it on the patients, but the little mini enema has had great success.
See, when the stool is very hard and impacted, when we try to give an enema, does we not induce, very painful experience?
Yes, so it does. That's why you don't want to use our mini enema if they're impacted. You want to disimpact the bowel first and then get them on the mini enema as a regular basis until the constipation is resolved.
So when you say disinfection means, do you need to do a manual disinfection under
Yes,
anesthesia?
yes.
Okay, I see. Thank you. Thanks a lot.
Okay, Margaret, thank you very much, Margaret. It
Yes.
seems that we answered all questions.
Okay.
And would you like to mention anything else?
No, I think we're good. Thank you so much for your time and your questions. And if you have further questions, they can pass it on to me, and I'll be more than happy to send any information that is requested, clinical trials, anything like that your way. So thank you very much for your time. I do appreciate it.
Sure.
Have a wonderful evening.
No, thank you. Thank you. Thank you for every doctors and our colleagues. They are participating in today's webinar.